My name is Carolyn Wester. I'm from the Tennessee Department of Health, and I have the pleasure of moderating this session. We'll have the same format as we have before, 10 minutes for a speaker, and then 5 minutes for questions. We'll have a short panel after. The only change that we'll have to the listed agenda is that we will skip through the break, allowing us to go for lunch 15 minutes earlier. So we'll go for lunch at 11:45. So our first speaker, Ann Gaynor, comes to us from Dr. Ann Gaynor, is the HIV, STD, and hepatitis and TB programs from the Association of Public Health Laboratories, and she'll be presenting on public health laboratory capacity in the United States.
Thank you. Okay, so why are we talking about public health lab capacity? So thankfully we heard from our commercial partners yesterday, and we heard a little bit about the clinical labs, but we've not yet heard about the public health lab capacity for HCV. So I'm going to talk a little bit about that. There's also, for those of you that are not familiar with the public health labs in the US, there are 11 core functions that they fulfill. Two of those which sort of encompass what we're going to talk about here today. One is disease prevention, control, and surveillance, and also the ability to provide reference and specialized testing. And so those two core functions are sort of what we're working on in the public health lab capacity. So obviously we know that screening is a very major part and imperative for effective prevention and control, and it's been at the cornerstone of HCV testing for a long time. A lot of this does happen in the public health labs for various diseases as well as hepatitis. Treatment before kind of looked like this. There wasn't a lot of options, and treatment now is a sort of massive number of drugs and different treatment regimens. And with that comes the need to actually distinguish between current infection and chronic infection. It used to be maybe a more academic exercise, but now that there are drugs, we actually need to discriminate those two things. The other sort of aspect of public health labs is that they frequently serve at-risk groups. They're serving as sort of a safety net for underserved populations. Many of those underserved populations are also the same sort of groups as aligned with sort of HCV risk, including HIV infection, persons who inject drugs, corrections facilities, and people who present to sort of public clinics as opposed to a private care provider or have insurance and those kinds of things. So that was another aspect of where the public health laboratory becomes really important as compared to your primary care or other methodologies for seeking service. And last but certainly not least is outbreak response. No matter where an initial test may have been performed, it almost always comes back to the public health laboratory if there's an outbreak. This is not a picture from GHOST, but we'll see lots of those later. I try to get a GHOST-like picture for Yuri. So they're in a unique position to coordinate with the public health department, as well as to coordinate testing for multiple diseases, as we saw with the HIV, HCV outbreak in Indiana last year. So in order to assess capacity, APHL, the Association of Public Health Laboratories, we have both state and local governmental laboratories that are members, and we survey them periodically. So for HCV, we did a survey in 2009, in 2012, as well as in 2015. Sometimes these are just HCV specific, sometimes they're in correlation with our HIV survey questions. And just of note, in 2013 was when the CDC recommendations got updated to include reflexing to HCV RNA. So just to keep that in mind as we're sort of going through some of the survey data. So one of the questions we've asked repeatedly over the number of years is, does your laboratory offer HCV testing? So we have the surveys in 2009 is in a blue color, in red is 2012, and 2015 is in purple. And what we've seen is a decreasing number of laboratories providing HCV testing. And anecdotally, sort of talking to a group of folks that met earlier this week, a lot of this came from the fact that there's a lot more point of care assays. And so a lot of that testing is now happening point of care as opposed to a laboratory-based assay. And so the need has dropped. Just to back up a step, the percentages that are shown are the percentages of responding laboratories. They may not be the exact same laboratories every year. We could look at that data, but just for here and now, it's a percentage of those responding laboratories. So of those that said no in that year, we then asked them in 2015 if they plan to add testing. And what you can see is that 60% of them basically have no plans to change that. So we have a number of labs that aren't performing HCV testing, and many of them aren't going to bring it on. A few that are going to bring on HCV antibody testing, and lots of them that weren't sure. So The other question we ask is, what types of HCV testing services do you offer in-house? So approximately, it's increased over the years, approximately 95% in 2012 and 2015 offer antibody testing, which is great. There's at least the screening sort of initial step is being done. There's a few that have moved to doing point-of-care tests in the laboratory, but you can see a very few are actually doing either a qualitative or quantitative NAT. There's about 11 labs total with only one overlap. They're doing both qual and quant in their laboratory. We did see the drop-off in REBA when it was discontinued, and there are a few labs that are offering genotyping to their clientele. So why aren't public health laboratories doing HCV NAT? So frequently when you ask public health labs why they're not doing something, the top answer is cost. So not surprising, it's not cost effective to bring on, and or there's not funding available to bring that testing on, followed by sort of the next sort of two questions of, it's not really being asked for. So their clientele is not requesting that, so there's not the push to do it as well. And so the last one, sort of a question, is the identification of current infection not prioritized within the public health system to the point where that's being requested of the public health labs? So just some thoughts on that. I mean, I don't think there's any one answer, but, you know, it's interesting to see that even though the recommendation came out in 2013, there hasn't been a huge change in practice in the public health laboratories as far as bringing on the HCV RNA testing. And so what are some other things that are upcoming and or game changers? So APHL, along with CDC, is working on exploring a shared service model for HCV NAT. So for HIV NAT, Bernie kindly explained earlier this morning that the NAT for HIV is that third step in the algorithm. And there's very few samples. And so what we've done for that is we have two APHL CDC sort of reference centers that allow access to the HIV NAT for any public health laboratory. So any public health laboratory for free can send their samples to one of these two labs and get HIV NAT. So every public health lab has access to that third test in the algorithm, even though it's not cost effective for every lab to bring it on. HCV is a different story. The volume is much different. It's the second test. It's not a third test. So it's a very different model, but APHL and CDC have worked together for a number of years on various different reference center models. We have one for vaccine preventable diseases as well as influenza. So trying to explore whether that's a need and whether that's a need regionally, whether that's a need across the country, sort of what does that look like, and is there something that we could do to help sort of fill that gap for public health laboratories, presuming they want to be doing it and they just can't bring it on because of cost. The other thing that we're bringing on, this is not necessarily going to change sort of the diagnostic aspect right now, but we are working on a pilot with Yuri and team to pilot the GHOST project in 4 public health laboratories that we did an RFP that closes today, actually. So we'll be selecting 4 public health laboratories to sort of work with Yuri and his group to sort of see how that actually rolls out in a real life setting in a bunch of different public health laboratories. And we'll hear from Tennessee later this afternoon about their experience thus far. Some other game changers, and this will be talked about, it was referenced, I think, by Bernie this morning, is that there's these Roche has now gotten dual claims, so their assays are now available for both diagnostic as well as quantitative purposes. So public health labs that maybe couldn't bring it on because they had to really be doing the qual based on reflexing and following CLIA, maybe have a little bit more flexibility now in bringing on these dual claimed Roche assays, and hoping that other sort of manufacturers follow that paradigm as well. And obviously we heard a lot about core antigen assays from the public health lab, and I think from any other lab, reflexing to another serology assay is much simpler, as opposed to a NAT assay in these laboratory systems. So obviously we have a ways to go for that, but we're optimistic that hopefully one of those makes it into the world of FDA-approved tests. And so in summary, public health labs serve a unique role in HCV diagnosis. The diagnostic capacity is decreasing as the need for testing continues to increase. So sort of looking at that as a whole system, are those tests going to commercial and clinical labs and that we're not missing testing, or is it really that we're not quite where we need to be to match the need? HCV NAT availability in public health labs is limited, but public health labs are well positioned for using advanced methods in sort of that reference center capacity for outbreak and surveillance using advanced technologies such as GHOST. And so with that, I will conclude. Thank you.
Over here. One pretty quick question. I know we're talking about hepatitis C, but so I'm a DBH member, so I had to ask about the other viral heps. The picture, the overall picture is pretty much the same, like compared to HCV when we are talking about the other viral heps.
So there's less testing for the other heps, I would say, than hep C. So hep B is, I have to go back and look at the data. Hep B, there is probably similar but slightly less capacity. And for all the others, there's so
zero.
A, there's some, but the down the alphabet further, not a lot going on.
How sad is that? Thank you.
Yeah.
So I have a question.
Yeah.
Obviously, the question that you were posing was to the public health laboratories on why they think perhaps they're not doing it. Has that question been posed to the health departments themselves, like the viral hepatitis teams or whatever? Because it'd be interesting to know why they're not asking for it.
Yeah, so I don't know if that specific question has been asked. I have been working, so NASTAD does a survey also of health departments, and Lisa Randall, we'll look at Lisa Randall in the back right there. So we are looking at trying to sort of tie some of the lab and the health department data back together and figure out where the gaps are and what we can do to sort of address some of those in a lot of areas that surround HIV and HCV testing, because there is quite a bit of disparity between how things are done with HIV than they are with HCV, and trying to figure out ways to leverage the HIV activities and work and money to sort of look at HCV a little bit more carefully.
Carolyn, can I give you 10 seconds on that? I think it's a complex answer. Those questions have been posed to both HIV programs and HCV programs because there's a significant amount of overlap, as you know. And I think that there are some pretty significant structural and communication issues within health departments to work through, sort of what we're identifying through these surveys and through other endeavors. And I'm going to talk about that a little bit more specifically, but I think this is sort of the work going forward for public health.
And in your survey, did you ask the PHL labs if they participate in the shared services model? They send their samples to a regional lab for testing for HCV, RNA, or antibody?
So we've not asked that question. I'm not aware. Yeah, we've not asked that question, so I'm not sure. We do know the ones that participate in the HIV shared service models, and we certainly know the labs that are doing and not doing it. We've not specifically asked those that are not performing it in-house, what are you doing? So something to consider.
So in Northeast region, we have quarterly public health laboratory director meetings that we, in the past year, we have discussed shared services. We used 2 tests as a model. One is Hep C, and the other one is arbovirus testing. That in New York State and our lab, New Hampshire Public Health Lab, to serve other states for Hep C testing. And the New York State and Massachusetts lab do arbovirus for other states. We have discussed that possibility and tried every possible way. And finally, we involved a lawyer from each state. Once a lawyer was involved, so no any solution. For Hep C testing, I talked to New Jersey State Public Health Lab, Rhode Island lab. So we had some issues could not be solved, so we couldn't do that. Then to Massachusetts, we verbally agreed that we will test Hep C for them, and they will test Zika virus for us. There's no written agreement, but we will just do it.
Right.
Yeah.
Yeah, so I guess, Salim, just to follow up, so although we haven't asked that formally in a survey, we do know that our labs are generally interested in shared service models and willing and open. The difference here is that the volume of testing is just so much different than what we've done in other shared service situations. So I think that's the challenging part of that. Thank you.
Our next speaker is Dr. Monica Parker, who is the Chief of Laboratory and Bloodborne Diseases, Wadsworth Center, New York State Department of Health. And Dr. Parker will be presenting on challenges in using laboratory-developed tests in HCV diagnostics.
Okay. Good morning. So I am a laboratorian. I'm from the Public Health Laboratory in New York State, the Wadsworth Center. But this morning, because I'm going to be talking about the challenges of using laboratory-developed tests, I'm going to be putting on my regulatory hat. What is a laboratory-developed test? Let's just start right there. And I've lifted this definition from the FDA website. An LDT is an in vitro diagnostic test that is designed, manufactured, and used within a single laboratory. And so this differs from the designed and manufactured tests that are completely developed outside of the laboratory that is going to use those. So those are the typical kits that we use in our laboratories that we purchase. And traditionally, I think in years past, LDTs have been relatively simple and not widely available. However, over the recent years, LDTs have really evolved. They've become increasingly more complex, and through some of the larger laboratory systems, much more widely available. There we go. Okay. And so in terms of the regulatory oversight for LDTs, traditionally the FDA has historically, I suppose, exercised enforcement discretion in terms of the review of LDTs, but because of the reasons I just explained, the increasing amount of complexity of the methodologies and the more wide availability of LDTs, the FDA has recently begun developing a plan for review and approval of LDTs, and we are anticipating that at some point. However, I am not from the FDA, so I'm not going to comment on that any further. But I am from the New York State Department of Health, and under New York State public health law, the department has regulatory authority over clinical laboratories that test specimens collected from New York State residents or collected in New York State. And through the department's clinical laboratory evaluation program, we have had a long-standing formal process for the review and approval of laboratory-developed tests, so that if a laboratory wants to use that test clinically on those New York State residents, they need to go through that process. And so that's why I'm standing here. And so just again, I just want to also sort of make the distinction between FDA-approved tests and LDTs. And so laboratories, clinical laboratories, and Bernie mentioned this earlier, really are bound to follow the package insert of the FDA-approved test when they are using that clinically. And any modification to that package insert constitutes off-label use of that FDA-approved device. Now, a laboratory can make a modification and use that for clinical purposes on patients, but they have to go through a validation process first. And so in terms of the regulatory oversight, a modified FDA-approved test really is essentially a laboratory-developed test. It becomes equivalent to a laboratory-developed test when those modifications are made. So what constitutes a modification? So any of the items listed here, again, I've taken this directly from some of the FDA documents that are available on the web, is really any change that's going to affect the performance or the intended use. And that's an important one that we're going to talk about further in terms of HCV diagnostics today. So any of these types of changes would constitute a modification. And so we've just mentioned that you can modify these tests, you can go through a validation process. There's always lots of questions in terms of what does that validation process really entail. So I'll talk a little bit about that, at least from our standpoint in New York State. And as I mentioned, we've had a process for reviewing LDTs, and There are certain requirements that when laboratories want to offer that test, they have to submit an application to the department. I know this is a very popular process for many of the laboratories. They love it. And that involves submitting the standard operating procedures and for all components of that test, and a full validation study with a summary of all the data, example reports for the various different results that can be produced from that test, quality assurance plan, any relevant references, and it goes through a formal review process. And so in terms of this meeting we're here today for, why is this an issue for HCV diagnostics? And so we all know, we've been talking about this algorithm, we all know that RNA testing is recommended for all anti-HCV positive individuals. And really, in order to ensure that that happens, sort of the best practice would be to have the lab reflex the antibody reactive samples directly to RNA testing. And so for the laboratory to use a test in that diagnostic algorithm, the test really has to be FDA approved, or approved at least, for diagnostic use. And that's where we kind of have run into some dilemmas. So there can be really good, sound, peer-reviewed scientific studies that might say that a particular test is appropriate for this situation. There might be clinical guidelines that advise and recommend the use of certain tests. But if that language and that intended use isn't in the package insert that was approved by the FDA, it really puts the laboratory in a very difficult position. Because they either then have to take on the responsibility of doing that validation study, or they do risk being cited by the regulatory agencies that oversee clinical laboratories. So it's a tough spot, because they know it's the right thing to do. I think we'll all know it's the right appropriate test, but they can't always just do that. And so Bernie's also talked earlier today about the different types of HCV RNA tests we have. And this table just shows these are FDA-approved qualitative RNA tests. So these are the tests that just tell you detected, not detected. And for the reasons that Bernie explained, that is, it tells you if somebody is currently infected, but there's more information that can be gained by quantitative tests. But I want to point out that these three tests are the ones that are approved here to aid in diagnosis. So this table shows the quantitative HCV RNA tests that are FDA approved. And all of these have been approved for management during treatment. And if you look at these three, actually, if you look at any of them, I'll point out right now, if you noticed, I don't know if you looked on the previous slide, but all of these have a limit of detection that is better, they're more sensitive than two of the tests that are approved to aid in diagnosis. But three of these tests are approved only for management during treatment. And so for a laboratory to use those in a diagnostic algorithm, like the one we have just talked about, then they have to go through that validation. As we know, there has been a big breakthrough during the past year, and so we do have one quantitative test that has the dual claim. It is approved for management during treatment and also to aid in diagnosis. So that is where we want to be with these types of tests, because it does allow you to then do a quantitative test but use it in the algorithm. So what does a laboratory need to do to validate a test, a modification of an FDA-approved test or an LDT? I'm just showing here a synopsis of the requirements for validation. They have to do sensitivity, reproducibility, interassay, precision, specificity, cross-reactivity, accuracy validation, and using samples of the appropriate viral loads and variants. It's a lot of work. So even if you're very strategic about the way you design your validation study, there's no question about it. It's a lot of work and it's a lot of expense, and it's up to the individual laboratory that wants to do it. So even if another laboratory has validated that test, you still have to do it again in your own lab. And I think one of the things I want to just sort of mention is that there's differences between the FDA-approved tests that are out there and how they've been approved. I think for the tests that we have for HCV and even for HIV, those are very strong tests. They have oodles of really strong performance characteristics in their package inserts. So if there is a modification being made, are there any concessions that we can make in terms of what we ask a laboratory to do in terms of validating them? And I think we have to ask a couple questions. First of all, what is the type of modification? Is it, a change from using it for managing treatment to diagnosis might be a pretty simple change to make, but are there other modifications being added on top of that? So if you start to make changes to the storage conditions of the samples, for example, and you still want to report a quantitative result, how can you be sure that that result is going to be reliable when you're now making other changes to the test? So if you want to do that, you have to do more validation. And also just really looking at what types of validation data are in the package insert. Does it make sense to have to repeat reproducibility over a wide range of viral loads if it's been done and shown to be accurate in a quantitative manner, to have to do that for qualitative? That may not make sense. So I think we have to think about what might be some concessions or exceptions that we might make to the sort of the full validation of a laboratory developed test when it comes to some of our modified FDA approved tests. Just final comments. It's just reiterating, it is the individual laboratory's responsibility to do the validation studies, and this includes the modified FDA-approved tests. I think if we do have some sort of standardized guidelines for laboratories, it can help them design those studies and make that process a little bit less painful and less of a black box. But it's clear that there's a lot of expense and workload involved. It's not trivial, and it's a major challenge for the labs to be able to do that. So I will end there.
I have a quick question for you, just to get it started. In New York State, in your public health laboratories, what kind of, if any, HCV testing are you all conducting?
So it's an interesting question. We actually don't do, right now, we have not been doing much in terms of routine screening. At the Wadsworth Center, typically we are trying to fill in gaps where those tests aren't necessarily available out in either the clinical labs or the commercial labs. With that said, we do respond to outbreaks. We are working with the CDC's group here in terms of developing the next generation sequencing for surveillance. We actually have a laboratory-developed HCV test that is qualitative and quantitative that we can use in some of these situations. We've gone through the validation process and have it approved for clinical use. We are now trying to work with our programs to help them with some of the they do a lot of rapid testing, but we're going to try and have them filter some of those samples through the public health laboratory to help, I think, sort of a win-win. We can help offer them some services as well as gain some more samples for some of the other types of surveillance projects that we want to do. Yes.
Monica, you mentioned a lot of times, and today on your slide it also says FDA approved, but first of all, everything you talked about applies to FDA cleared tests as well.
Cleared,
right?
sorry, yes, correct.
And I mean, that's sort of what we're stuck with HCV and HIV, is the reason the manufacturers don't go for it is that the bar is so much higher for FDA approved than it is for cleared, right?
You probably know the answer to that better than I do.
Yes, yeah, I do.
So please answer that. I don't know. I'm using those terms incorrectly.
Well, no, but people have always asked about that because laboratories, folks, in general, most tests are cleared. And people, whenever I would say approved, they're like, oh, don't you mean cleared? And that's sort of the difference. And I know that the TB people 2 years ago actually managed to get the TB test down classified from the PMA thing to the cleared thing, and that changes the whole structure.
No, I know now. I get what you're saying. Yes, absolutely. But they're in a class that has higher requirements for that approval. Yes, and so
yeah, they're considered high risk, and I'm not sure why that's high risk and flu isn't. But
I don't know either. And if you look, well, a lot of the LDT stuff is going to go through a risk-based assessment as well. And if you look at all the, you're not using a standalone test in most cases. They're used within an algorithm. There's a lot of reasons why I think it's a bit. Yeah, I think also I agree with you, it's a bit much. Yeah.
The second thing I just wanted to ask, because it had happened a couple of times in the past when there wasn't an available test, is where big groups or labs like yours and other large public health labs would do a validation, submit that to CMS, and then that would allow other labs to do a limited validation with just a small number of specimens? Is that?
I think our attempts at trying to allow that, it just doesn't seem like there has been as much, the responses we've gotten is that they really aren't going to go for that. We've asked for that, well, in a completely different situation, but being able to use, for example, HIV rapid tests on infants or children, and being able to, we would do a full validation, but we still were getting a lot of negative feedback from the laboratory oversight agencies. Yes.
I guess that's the answer to my question. As a clinician, we've been using the quantitative tests forever to diagnose patients. Yes.
Yes.
They can't.
So that's the thing. If a physician orders a test, the responsibility for the lab is not to say how are you going to use those results. It's really a conundrum.
That makes some sense to me.
It's just that if you have to constantly rely on somebody to order that, it would happen more readily if the lab could just automatically do it. It's just this, there's nothing scientifically wrong with using it for that purpose. It's good.
What some places have done is the physicians at hospitals have done a standing order.
Yes.
So that they will do quantitative, because it's okay for a physician to order it, and it's okay for the lab to do it if the physician ordered it.
That's right.
In fact, laboratories that are running these tests do not know when a clinician orders the test, because for confirmatory testing or monitoring during treatment or monitoring SVR, we have no idea.
Exactly, and that's actually the beauty of it. So if it is ordered, you can do it, and you don't have to.
It's just that it cannot be part of a reflex algorithm from a laboratory for diagnostic purposes.
Yes, if the laboratory is being inspected and they look and they want to see your report and this was a diagnostic test, show us the validation data where you validated this test for that purpose, and if you don't have it, ding.
We'll take 2 final questions. If we can make them brief, that would be great.
Yeah, I'm not sure if this is actually a question to the CDC, but again, as a clinician, this just like makes my head explode listening to this. And for those of us that are trying to implement reflex HCV RNA testing, trying to figure out how to give advice to other hospitals. The commercial labs, I think, have figured it out, but for those that work with, local hospital laboratories, what is the advice of the CDC on how to deal with this? I mean, I don't understand what the answer is.
Who's here from this?
I do not have an answer to the question, but I have a question. So, Monica, my question is the validation criteria that you showed, that's for the New York State. Is that also consistent with the CLIA validation? Do you use the same data if you have to?
It's based on, it's consistent. It is based, and in New York State, they have a CLIA exemption, and so that means that they're following everything that CLIA requires, at least minimally. But yes, it's based on CLIA, it's based on CLSI, it's based on those types of requirements.
I was just wondering if APHL can help here, can develop these criteria that can be used by all the labs, so that you don't have this variation from one state lab to another state lab.
So we have worked on, can anyone hear? Is this on?
Yes.
Okay. So we have worked on this issue. The problem is that when you provide very clear guidance about validation processes, the organization that regulates does not like that. So we've done it for CT and GC for extragenital testing specimens. And we had a checklist that had very clear numbers in it, and that was, it's now removed from our website. So it's certainly something we can do, but the other problem that hasn't been addressed yet is that the way CLIA works is that they have recommendations for best practices for validation verification studies, but the person that's actually looking at those is an inspector, and each inspector is different, and laboratories have, so there's 2 issues. There's different inspectors who look at things in a different way, and so there's not standardization in that process. Also, public health lab directors or clinical lab directors have different interpretation of CLIA rules and will interpret modifications and those kinds of things differently. So it's very hard to standardize because at the end of the day, the public health or the lab director and the inspector are the ones that are sort of looking at the data, and those vary greatly. We've heard of regions where the clean inspectors are very challenging, and in places where they are less so.
Linda Thomas, Tennessee Department of Health. I just want to chime in. Thank you, Dr. Gaynor, and thank you, Dr. Parker, for clarifying that, because I think a lot of people don't understand the process that state public health has to go through to implement and the challenges of performing a test. And I think you've cleared that. One thing for the state of Tennessee is not only do we have to go through CLIA, but we also have state inspectors. So some states have state inspectors and others don't. Some of our state inspectors are even harder. I'm not saying harder, but it's a little bit more challenging because states have regulatories that are different from CLIA, and so we have to go above and beyond just that.
Yeah, I agree, because as I said, I am a laboratorian, and our state inspectors are definitely very, very difficult. Yeah.
Well, I apologize. I realize there are more questions out there, but with respect to our next speaker, I'd like to welcome Dr. Stephen Lavelle, who's the regulatory scientist. Thank you. He's a regulatory scientist at the FDA, and Dr. Lavelle will be talking about regulatory issues. Perfect timing.
How do you? Good morning. Thanks for the invitation for this meeting. This is going to be a very basic overview of the process for obtaining a PMA. I did change the title of my talk. It was originally regulatory issues. I changed it to challenges because I don't like that word, issues. So my branch covers the hepatitis products. So essentially, any submission that comes through will eventually end up on my computer screen, whether that's good or bad. Just to give an overview, this is really basic. So this is related to the classification of diagnostic devices. It's risk-based classification. It goes from lowest risk up to highest risk. And this isn't risk from the device falling on someone's foot or cutting them. It's really the risk, the risk of a false, the effect of a false positive or a false negative result, what that risk would entail on the patient or on public health. And you can see as you go from lowest risk up to highest risk, as we just heard, there's more regulatory control. So the class 3 devices have the highest level of regulatory control. And as we just heard, all of the HCV diagnostic devices currently are class 3 devices, which are the highest risk. And actually Europe is also revamping their regulatory requirements for medical devices, and they've also put HCV along with HIV as in the highest classification, which is class D. So going across the bottom there, the highest risk devices, class 3, require pre-market approval, PMA, versus a 510K, which is mostly the class 2 devices, versus exempt, which would be, most of those would be in the class 1, the lowest risk. The good news for small businesses, if they want to file for a PMA for HCV, the first PMA is actually lower price or cost in terms of user fee than a 510K. It's zero. And then also for small businesses, there's a 75% discount on the user fee. So the good news is for small business, they don't make too many sales, they'll stay in the lower discount rate. On the other hand, if they make large profits, then they can start paying a higher user fee for the PMA. This just gives an overview. This is all information off our website that I collected yesterday. Basically, there's 3 product codes, and you can see the grouping there, HCV antibody, and then the quantitative and the qualitative RNA tests in the middle. And as we just heard, the quantitative HCV RNAs, viral load assays, are also now starting to get a diagnostic claim to go along with it. We've got a total of 18 PMAs, but you can see the number of supplements. It's well over 300. And this is an opportunity for manufacturers to modify their original PMA submission. It's also related to manufacturing changes and so on. So there's a level of scrutiny on the PMA products because of their risk. So What's entailed, I'll just talk about PMA submissions from now on. What's entailed in the review of PMA submission, it's a much higher level of review than for 510K. It involves a team, and there's three key components. First of all, there's the in-depth review of all the clinical and non-clinical studies, which will bring in statisticians, et cetera. And these studies are to support the intended use of that particular product. So it's really, really important to have those studies matched up with the intended use. You don't want to come in the door with a intended use of that product and the studies don't support it. And the second aspect is a review of the quality systems and GMP. So it's one thing to design a really good test, but it's another thing to continue manufacturing of that particular test and have the quality systems in place to maintain it. Then there's also a review by BIMO, the Bioresearch and Monitoring people, and basically they look at the clinical study that's associated with that PMA submission for patient protection and mostly data integrity. So basically for the review, all three aspects have to be acceptable for the PMA to be reviewed. It's three separate groups doing the review. Fortunately for the quality systems and GMP, the second bullet and the first bullet, we have those personnel are actually embedded within our branch or division, which actually makes for a smoother review process. So I just going back again about the intended use, this is really the key element of the diagnostic device. So some variables that could be in the intended use would be the population that's being tested. Is it going to be a presumptive result? Does it need to be followed up? Is it a presumptive positive, presumptive negative result? And there's also detection versus quantitation. And as I said before, really the clinical and non-clinical studies flow from this intended use. And pre-submissions where we have dialogue with manufacturers who are interested in developing a test, they're extremely useful for planning the studies to support the IU. These are free of charge. We spend a lot of time, reviewers spend a lot of time talking with manufacturers who are proposing tests. For PMA, I think it's probably not the best idea to come in off the street without having several pre-submissions to discuss it. And that's where the intended use statement can be looked at closely, as well as the supporting studies. We'll also bring in statisticians for those talks to make sure that those studies are statistically rigorous. Okay, so this is actually timely. Talking about the intended use. So the earlier viral load assays that were approved, and you see the parts are highlighted in blue. And I think Bonnie Branson mentioned this morning that the earlier tests, when they were approved, there wasn't any thought about using them for a diagnostic test at that point in time. So those were for quantitation of the HCV RNA, as you can see at the top, and for the management of infected individuals. There were no studies done to confirm the presence of a HCV infection with those assays. The manufacturers at that point were not interested in doing those studies, and so really could not give them a diagnostic claim because there was no feeling or no knowledge of how they would work in a clinical use setting for diagnosis. So we had heard about the issue of the issues with not being able to go directly from the positive antibody result to a quantitative assay. We'd heard from several labs, and also our connection with ALHP. We had heard about the difficulties and the potential for the increased costs. So we urged the manufacturers through pre-submissions and by contact to add diagnostic claims to the viral load assays. So any new submissions that are coming in for a viral load assay, we would discuss that during the pre-submission phase and say, why can't you add a diagnostic claim? We've heard that there are issues. with testing antibody and having to go to a qualitative assay. So the studies that we had proposed, there were actually 2 studies proposed for the manufacturers. The first one was to determine the positive % agreement for a diagnostic claim, and that was to evaluate the specimens from the patients with positive anti-HCV result. The number of specimens we were talking about there was several hundred. It was around about 200 specimens. And then a second study was just to make sure the specificity was okay. And so testing specimens from patients with those various conditions. And I think the total number there was also of the order of a couple of hundred. And then also there would be no additional analytical studies required, potentially, to put on the diagnostic claim to go along with the viral load claim. So actually we do have two products that were modified. Originally, viral load assay, well, not modified, sorry. One was modified. It came in as a supplement. I think it was one of the earlier Roche viral load assays they actually added through the supplement process. And then the second one was a new approval for the Cobas 6800 and 8800. And so the intended use now for those types of assays, so they kept the blue portion, which is the quantitation aspect, as well as the management of the HCV-infected individuals. And then the red portion was added in for those 2 assays. So you can see that the red portion speaks to the diagnosis of HCV infection in the listed populations. And then down the bottom, the red strikeout is the removal of the not intended for diagnostic testing. So I think that was successful talking with the manufacturers, and I think it also points out the value of the pre-submission process, where we can have those sorts of dialogues with the various manufacturers. So that's to do. That was essentially the section on the analytical and clinical studies to support a PMA. The third aspect was a BIMO. I won't dwell much on that. Essentially, they inspected the collection of the testing sites that are used in the clinical study, mainly for patient protection, to make sure that patient rights are protected, as well as for data integrity. We actually encourage diagnostic test developers to audit the sites themselves before they start their studies, as well as during the studies, so they don't have surprises. And then the other aspect about the manufacturing, to make sure that the products are manufactured reliably and to a high quality. So the inspection of the reviews are done during the PMA process, or the PMA review process. It's just not the manufacturing procedures and the process validations. You can see down the bottom there, the emphasis on design. It's extremely, so that goes back virtually to the feasibility studies carried out by R&D to make sure that they're addressing, the needs of the end user. So anyway, the bottom line was the PMA process is to ensure the high performance and quality of the devices because of the high risk. It's not an inflexible process, and like I said, for small businesses, not necessarily expensive. And also put a lot of check marks up to pre-submissions, because that really helps to lead to a quality product. Thank you.
Steve, right here. So in terms of your definition of intended use, detection versus quantitation, so Monica showed earlier that for HCV RNA, the quantitative assays are actually performing better in terms of detection than the qualitative assays that are approved for diagnostics. Is it time for FDA to modify these definitions and have these assays approved for detection and quantification simultaneously?
Detection is basically a positive or a negative result, whereas quantitation will give you the number. And it's just that as the technologies have improved and the instruments have improved, companies like Roche, their later assays, which are quantitative, are actually more sensitive, as you said, than the qualitative assays. But the qualitative assays are still solely for detection. They won't give you a number.
I have a question to your right over here. On your slide regarding quantitative, or the approval for the quantitative for diagnostic purposes, is it requisite that it's a step 2? So does it have to follow an antibody test? Because in the red wording, it looked like it was only approved as a diagnostic test following a positive antibody test. Is that correct?
Yes. So the viral load assay with a diagnostic claim has to have an antibody positive result first. Yes, just like the qualitative assays.
Over here. Yeah, I was wondering, a number of companies have tests that are CE marked, but not approved here in the U.S. When they come to the thought of bringing their tests to the U.S., I wonder if you could comment on sort of the harmonization of data, because there's a lot of data that was used to get the CE marking. How do you view that data in terms of a submission here in the U.S.?
Yeah, that's a good question, and it may be changing soon too. It may be tests get approved before the CE mark going forward with their changes that they're undergoing right now. But so those studies are valid if the studies were carried out appropriately and the data is good, then we would accept those clinical studies. So those companies are free to submit the clinical studies and the data. They should have some testing done with the U.S. population, although that's not etched in stone either. If the population they've tested is similar to a U.S. population, there's a high probability that we would accept that data. But it boils down to when the review is done, does it meet the standards of our statisticians?
Can you tell me what a limitation statement means in the package insert? I mean, the place that we've been stuck with respect to using rapid tests to test infants is based on the limitation statement, and that doesn't seem to be part of the intended use statement. The limitation says insufficient data have been collected. I'm wondering where that fits in this whole thing. So in this particular case with the earlier qualitative assays, it was put in with the intended use statement because there was just no data available to justify using the test for diagnosis. The limitation is putting in the limitation sections a lower level of a requirement. I can't say much more than that.
Okay, thank you.
Sorry, can I just comment on that? I know, I agree with you, and we made that argument to CMS for those purposes, and they still would not allow it.
It seems to me that the limitation statement doesn't mean that FDA didn't approve it, and so it's a CLIA problem and not an FDA problem, right?
There weren't enough patients in that category to approve it. I will say the newer tests are putting it in the intended use statement, but even in the older ones, it wasn't. It was still restricted. They were citing labs that were doing it.
Okay, we will hold other questions till the panel discussion at the end, but thank you very much. Great. I'd like to welcome Dr. Chapko up, and Dr. Chapko will be speaking about the cost effectiveness of various HCV testing strategies, and he is a research professor emeritus at the School of Public Health at the University of Washington. Thank you.
Thank you. Let's see. The talk that I'll be giving is based on a paper that we published in Hepatology in 2015. The list of co-authors is on there. Basically, it was a study that was a collaboration between the CDC, the Department of Veterans Affairs, and the University of Washington. In terms of methods, we we're interested in comparing 6 different testing strategies for hepatitis C. The first 3 strategies involve lab-based antibody tests. The first one, the very top one, is a reflex test. The second one for NAT. The second one involves a 2-tube procedure with NAT. And the third one involves the patient returning after a positive antibody test for NAT. And then the 3 latter tests involve OraQuick. The first one involves a finger stick, followed by NAT if the finger stick is positive. The second 2 involve venipuncture. The first one with a reflex test, and the second one with 2 tubes. Our 2 primary outcomes were viremia sensitivity and cost per individual tested. We used decision analysis to do the cost effectiveness analysis. Let me get my pointer here for a second. Basically, this is a decision tree, and the first several boxes, well, these 2 boxes indicate whether a patient is truly antibody positive or negative. These boxes indicate whether the patient is viremic or not, if they are truly positive. And then the subsequent boxes indicate the results of first the antibody test and then the NAT test. And what we do is we incorporate into the decision tree the costs of the various tests and the sensitivity and specificity of the various tests, which basically guide a patient down a given line with various probabilities. At the time of our doing the paper, these were generally the antibody tests that were available, and we wound up selecting VITROS as the sort of the marker test because its sensitivity and specificity was sort of in the middle of the range of sensitivities and specificities for similar tests. And then for OraQuick, for venipuncture, we used its sensitivity and specificity, and for OraQuick finger stick, we also used its sensitivity and specificity, and you can see that it's the finger stick is a little bit lower in those characteristics. We also incorporated the sensitivity and specificity of the NATs. We primarily concentrated on the quantitative NATs and specifically used the real-time HCV test as our sort of baseline test that we used in the analysis. Let's see. This is, I think, the slide that everybody's been waiting for. It reflects the cost of the various tests. These costs are based upon Medicare and Medicaid reimbursement rates for the tests, and presumably reflects somewhat accurately the relative cost of the tests. So, for example, people were wondering what the relative cost of the antibody versus a NAT test is, and at least in the terms of the quantitative test is about 3 times as expensive as the antibody test. The other parameters that went into the model were first the 3.5% prevalence rate for antibodies in the 1945 to 65 cohort. The spontaneous clearance rate that we entered was 30%, and the rate of return for individuals who were asked to return for the NAT was set at 90%, maybe a little bit optimistic given, I think, some of the data that was presented earlier, but you'll see the impact of it fairly quickly. So this is the major analysis that we did, and listed along the bottom are the 6 different tests that I described, or testing sequences that I described before. The bars represent the cost of those sequences, the average cost of those sequences per patient, and the dollar amounts for those are presented here. So you can see that most of the costs are about $30 on average per patient. Obviously, somebody who goes on to NAT, the cost would be higher. But the average cost per patient tested is in about the $30 range. The other critical bit of information is the viremia sensitivity of the testing strategy, and that's represented by the dark line and dots. And if you look at it, in terms of viremia sensitivity, the 2 laboratory-based antibody tests, or the testing strategies that involve the laboratory-based antibody tests, have the highest sensitivity. The OraQuick tests have the ones that use venipuncture also have relatively high but slightly lower sensitivity. And then obviously the testing strategy that involves the patient coming or the individual coming back for the NAT reduces the sensitivity of the test considerably. And then the OraQuick finger stick also has somewhat less sensitivity because basically it's a less sensitive test for the antibody. Oh, yeah, let me go back for a second. Okay, so one of the questions is, which I'll try to answer quickly, is that the sensitivity of the lab-based tests is higher, but also the costs are somewhat higher than the OraQuick. And the question is that higher sensitivity worth it? And I did a quick calculation, and roughly for each individual who is viremic, it would cost an extra $1,450 to identify that individual, which seems reasonable. There are obviously circumstances under which one would want to use OraQuick, but it seems reasonable to pay the extra for the lab-based test. The previous slide was based on the quantitative NAT. This is the slide, a comparable slide using a qualitative, and as you can see, the sensitivity goes down significantly if a qualitative test is used. This slide presents a comparison of the various tests that are antibody tests that are available, and they're ordered by their specificity with regard to detecting an antibody. And as you can see, as the specificity goes down, the cost goes up. And the reason for the cost going up is because you're winding up doing, there are more false positives, you're winding up doing more NATs unnecessarily. This slide presents a variation in the prevalence of Hep C in the population being tested from 2.5% to 15%. And as you can see, the sensitivity of the tests of a given test sequence or strategy doesn't vary as a function of the prevalence, but the cost clearly does increase as a function of the prevalence. And I think someone was asked, or a couple of people were asking earlier, at what point would it be worth going to just doing a NAT initially and skipping the antibody test? And given that, I did a sort of a back of the envelope calculation just a few minutes ago, actually, and if you extend this up, at a prevalence of about, don't quote me on this, but it's the kind of analysis that one could do a bit more formally. But if you extend this out, basically at a prevalence of about 70%, the cost of this testing sequence here would be equivalent to the cost of just going ahead and doing a NAT. So it's obviously, it would have to be a very high prevalence population to do the NAT first. Okay, conclusions. We concluded that any of the following 4 testing strategies could be used, either of the laboratory-based antibody tests, either reflex or 2-tube, and either of the OraQuick tests with venipuncture. With regard to the OraQuick finger stick, it certainly can be used under, we concluded it could be used under circumstances where the venipuncture or a laboratory test wasn't appropriate. With regard to the specific antibody test that should be selected, one should obviously take into account sensitivity and specificity, and that with giving most weight to the sensitivity of the test. Finally, well, let's see, the fourth one is that the use of quantitative NATs is preferable to qualitative NATs. We've obviously had a lot of discussion of that. And finally, that the strategies requiring the patient to return or the individual to return for a NAT should be avoided whenever possible. Thank you.
I had 2 very quick questions. The first, when you said the threshold at which your back of the envelope calculation showed, was that 70 or 1717?
Sorry, 70.
Perfect, okay. And then the next question was just, I guess, your thoughts about why the sensitivity would have gone down moving from qualitative to quantitative, because I would have thought they would have had the same limits of detection. I mean, from quantitative to qualitative.
Yeah. Let's see, I'm a social scientist, not a lab person, so I don't know technically why, but we basically based our calculations on what were in the package inserts in terms of sensitivity and specificity of the tests.
Respond to that?
Which quality, was it the Hologic qualitative test?
Yes.
Yeah, okay.
Yeah, so the limit of detection of that one is low. It's as low as or lower than
Okay, so it may have been more to do with the qualitative test that was selected as opposed to lumping them all together.
Yes.
Okay, thank you. And thanks.
Hey, excuse me. When you determined your cost, was it basically just based off of CPT code reimbursement from CMS?
Correct, yes.
So you didn't include any potential soft costs in there, like bringing a patient back in to disclose a result, or any staff time or anything in regards to that?
That's correct. The assumption was that the CMS costs somewhat reflect those. Obviously, there's variation between clinicians and clinics, et cetera, with regard to the amount of resources that they really do put into a given testing strategy. But we assume that, roughly proportionately, the cost of an NAT versus an antibody test, et cetera, would be roughly proportional to the reimbursement by CMS, and that even if everything was higher, you would wind up with the same sort of conclusion.
And then I guess my follow-up question to that is, knowing that a lot of the times the price that people are paying can vary vastly from what the reimbursement is. Did you reach out to get any kind of real-world examples of what they're paying for running a test versus sending it out to a reference lab or any of those?
No, we didn't. And again, how efficiently they wind up doing the tests would clearly, to some degree, change the results.
Thank you.
For the reflex versus two-tube strategies, did you take into consideration the possibility of an increase in false positive antibody or false positive NAT results that, based on what Bernie was talking about this morning, of using the same tube? And did they just wash out, or did you not consider that?
We unfortunately did not consider that.
I guess the other question I have, which is not easy for your model, but it never goes to the distal outcome of whether people receive their results of these things. It's just how much the test costs. And so you say you avoid the strategy for return NAT because people don't come back, but none of these take into account whether or not anybody ever got those results, does it?
Correct.
So this is just based on the laboratory. So if you did all this additional NAT reflex testing, but people never got the result, that would then be a more expensive strategy than bringing them back for the NAT, wouldn't it?
I'm sorry, the last part of the question?
If you did reflex NAT on everybody, but a third of the people didn't get their results, like the people who don't come back for NAT on a return visit for NAT, that would be a more expensive strategy, wouldn't it?
Yes.
Potentially, but it might give the public health surveillance folks opportunity to use data to care when we get those resources. At least you'd have a confirmatory result on the books.
On the books, it's not the same as somebody knowing it.
But within but in terms of growing this continuum of cure, clearly we know from the HIV world that we can use that data to determine whether someone's confirmed in care needs additional navigation services. But it's a great point. And Dr. Kim, and while Dr. Kim's asking his question, if the other panelists can come on up, and we'll finish up over the next 10 minutes.
Well, I'm hoping that this question is more intelligent, my last one. In your base case scenario, you assume that 70% of antibody positive will be NAT positive, correct?
Yes.
Was it an influential variable in your sensitivity analysis?
No.
So it didn't matter if you have a pretest probability of 95% that NAT will be positive in a given individual with antibody compared to 50%. It didn't matter?
But those probabilities are basically you're asking if you have a cohort, I think you're asking if you have a cohort with a high probability or a high prevalence of HCV, would the testing strategy be different? And the answer is yes, but that's different.
No, that was my question.
Oh, okay.
Given antibody positivity, the prevalence of NAT positivity, that your base case scenario was 70%, right? So did you try to vary that and see if it had any significant impact on your bottom line?
In this example, we did not vary that, but we've done a similar analysis before, and it didn't make a whole lot of difference in terms of selection of specific strategy.
Okay, thank you.
Thank Dr. Chapko again. And we will now open it for questions, the entire panel. And while you're thinking of your questions, I was asked to just remind everyone, for those of you who may not heard, that arrangements for a taxi from the CDC to the airport can be made, and LaShonda Wise, who's outside at the table, would be happy to help you with that.
Can I ask one more question? So this, when you made a statement that if you change the strategy, it would cost $1,500 more to pick up one more positive patient, and
Yes.
you thought that was reasonable. And I was thinking the same question yesterday in the session for resource poor setting Camu's presentation. What makes it reasonable? And how do you define that based on the locale? And if you have to go to a government and say, this is reasonable, what is the theoretical basis that you would make that argument? I don't know if this is an answerable question, but...
Okay. What I did was I actually looked at what the cost was per, if the prevalence was 3.5%, what the cost is per individual that you identified using one of these selected strategies. And it winds up being, if I remember correctly, about $900. So the $1,400 is sort of in that range, and from my perspective, that seemed like the amount you're paying, or the order of magnitude that you're paying anyway for detecting people who are HCV positive.
In the cost effectiveness sort of realm, people talk about willingness to pay to purchase 1 year of health life or something like that, but that is pretty standardized for that metric. But for this metric, picking up a new case, diagnosing a patient correctly, or being able to help the patient, what is your social science, principle to go about answering that question? I guess that's what's the methodology would you use to define that value?
If you want to put it in a sort of a willingness to pay context, that the fact that we seem to be willing to pay about $900 to use one of these strategies to identify one person who's HCV positive, that $1,400 isn't all that much more, and it would seem to me reasonable. That's sort of the justification that I gave. That it's reasonable to pay $1,400 for finding one additional person.
So maybe we should look at like HIV case detection cost or TB or something like that.
If I can ask Dr. Lovell for a second. You had talked about the over 300 supplements with respect to the RNA assays and stuff like that. When someone has an existing test and they didn't get the indication for diagnosis in the first place, what does coming in for a supplement exactly mean? What does the manufacturer have to do?
So in this particular case, we did talk with the manufacturer, and we had a pre-submission first to discuss the studies with them. It wasn't necessarily that. It's also got to fit in their business plans, and quite often it's not necessarily the highest priority. So, so that they went and looked at the studies that we had proposed and thought that that was reasonable. That they could bear that cost. And I can't remember how long it took before they came back. In this particular case, it was a 180-day supplement, which means it's 6 months or less review time. Does that answer your question? For that particular type of submission, it's about $39,000, I think, give or take. I can't remember exactly, but Panel Track is getting up there. It's probably close to $200,000. Now, Panel Track would usually Panel Track has that would be also a change in the intended use, potentially a lot of clinical data and a lot more review time. And we figured in this particular case, so we would go with a 180-day supplement.
I wanted to go back to the cost and cost effectiveness question for just a second. My question is two parts for Dr. Gaynor and Dr. Chapko. And the first part of it is I heard Anne say quite clearly that cost is an issue for laboratorians in terms of HCV diagnostics. And I'm curious to know if we have any sense on whether cost effectiveness is part of their consideration in making decisions about strategies, or if it is really just about the bottom line. And the corollary question is, to what extent do you feel like adapting, or could this model be applied to public health decision-making around laboratory resources. So discuss.
So my comment would be that I think the sense I get is that the upfront cost is scary enough that a lot of times it doesn't get to the decision about cost effectiveness. Buying the instrument, buying the protocol, making sure you have staff time, doing the validation or verification or whatever needs to be done, depending on what test you're bringing in, is sort of a very scary barrier, especially if there's not the push from somebody asking for that test. I think certainly there are considerations for cost effectiveness, but this goes back to sort of conversations about labs billing, and Monica and I were talking about this a little bit earlier, like, do our public health labs know how much it costs to run a given assay? Probably they have an estimate, right? But they're also they're at a very different place, right? They're trying to not lose money as opposed to making money. So they're in a very different position. So I think certainly cost effectiveness is important, and tools to help with that I think are useful. But I think a lot of times it's the barrier of bringing on something brand new.
Let's see, from my perspective, two answers. One, for anybody doing a test or implementing a testing strategy, that what this analysis does is it gives you information with regard to what would be the most appropriate strategy to use. In a sense, this isn't a formal cost effectiveness analysis because it doesn't involve all the downstream costs of actually identifying somebody, getting them on treatment, avoiding the consequences of liver cancer, the downstream costs of hepatitis C. And from that would take a whole nother, sort of order of magnitude type of analysis to look at that per se, i.e., I mentioned before it's costing about $900 per person identified. Is that cost really worthwhile? Does it pass muster? So one would have to do that analysis or analysis along that line to determine from a public health or anyone's perspective whether these testing strategies are really cost effective in the more general sense.
I'd like to just remind those asking questions, because we're being webcast, to identify yourself and your affiliation before your question.
Okay, Gilberto Baum, Division of Viral Hepatitis. So a very quick question for Dr. Chapko, back again. So from your presentation, I saw that, in settings when you have very high prevalence, going straight to NIT testing is worth it. But how about places where the prevalence is not as high, but resources are still limited? Like, what would be the value of core detection, like detection of core antigen, right? And if it's pertinent, what would be the price? Like, I guess I should know the answer, but I really don't. So I was wondering if someone in the room knows how the price for core antigen detection compares versus RNA detection or antibody detection, just compared to the prices that you showed during your presentation.
Yeah, I don't know the answer.
There are at least 2 or 3 papers that do the cost-effective analysis for core antigen versus RNA, and I don't have the references right on hand, but I can provide them later. I know what they are. So I don't know how to forward that or present that to... Yeah, okay.
Thanks.
Yeah, I was going to ask that sort of along that same line. The model you developed and was published, I guess you could use the same model and factor in a core antigen test with a presumed price, of course. Yeah.
At the mic in the back.
My name is Mustafa Aladin, former UCMED infectious diseases researcher, and my question will go to Dr. Monica Parker, related to the laboratory developed assays. I'm just wondering about such kind of testing or assays. It can be used for patient care and treatment decisions, or it can be used or just for research purposes, where I come from, we used to develop such kind of assays, and it will be just to support our surveillance studies, not for patient care. Thank you.
So that the tests can be used, but the purpose of going through the formal process of submitting a validation study and having it reviewed is if you can get it approved, then you may use it for patient care. And in some cases, those are tests for which there may not be a commercially available test. So, for example, my lab has a test for HIV-2. It's uncommon. We can validate. There's many other areas of infectious diseases, and quite often they're public health labs, but there are also a number of other commercial labs that are developing tests. So they can be used for clinical patient care under those circumstances.
Okay, why we do such kind of work? Is this to be more cost effective or just to get better sensitivity and specificity? What's empowering you to do such kind of work?
So are you asking what would be the reason for going through this
Yes,
process?
ma'am.
Well,
Yes.
in some cases, there just are not tests available for, there are not tests on the market that you can purchase. So sometimes there are not tests, but you still have a need to provide that type of service, so that would be one reason. In some cases, maybe there is you have a very low volume, you cannot afford a very expensive instrument system, you only have occasional need to run some of these tests. There's various different reasons why labs may choose to go through the process.
Thank you.
Okay, well, we are on time now for our originally scheduled lunch, so we'll be back at 1:30, but please join me in thanking our panelists for a great session.